Thanks for joining us today. I'm really excited about this subject matter and our two speakers. I'm going to introduce them both to you. Dr. John Farley, who is a retired colonel, received his undergraduate degree at the U.S. Military Academy, medical degree in the uniformed services at the University of Health Sciences, did his residency in OBGYN and fellowship in GYN oncology at Walter Reed. He is a gynecological oncologist with Dignity Health Cancer Institute and serves as the division head for GynOnc, Dignity Health Cancer Institute at St. Joseph's Hospital and Medical Center, and he is a professor at the Creighton University School of Medicine. We also have Anne Marie Jackson with us today. Dr. Jackson received her medical degree from the University of Illinois in Chicago and completed her residency in Santa Clara Valley Medical Center. She is a gynecologic surgeon at Santa Cruz Medical Group and also serves as the chief medical officer. So I'm going to get out of the way and get started on this conversation today about cancer screening and in GYN cancer screening. It's been a topic of my interest over the years. I know it's always shifting data and evidence and what's the sequence of this. So I'm excited to hear this conversation. So I think Dr. Farley, you're starting. Is that right, Gary?
Yes.
Yes, sir. Great. All right. Take it away, Dr. Farley.
Thank you for allowing me to be here and to present on cervical cancer screening. And when we talk about gynecologic cancer screening, really cervical cancer is the only disease that we have good screening modalities for. Unfortunately, ovarian cancer and uterine cancer, except in some certain high-risk populations, there really isn't much with regard to screening in those populations. We'll talk a little about the natural history of HPV carcinogenesis, talk about screening used to prevent cervical cancer, talk a little bit about the ATHENA trial, which is what set the standard for primary HPV testing in the United States. So for the first case, or for a case, we have a 60-year-old labor and delivery nurse who's very responsible, got Pap smears all of her life on time, and she presented with advanced stage cervical cancer. She received chemotherapy and radiation therapy, was NAD, but because of the radiation had a pelvic fracture. So for this patient, is this a failure of Pap smears? And can we do better in this population? Just talking about human papillomavirus in general, there are over 140 known types that have been infected in humans. Only 40 are known to be carcinogenic. About 80 million Americans in the United States are infected with human papillomavirus, and we can expect about 14 million new cases every year. Human papillomavirus is very carcinogenic. If you look at cervical cancer, the odds ratio for developing cancer in someone who's infected is about 435. And if you look at smoking with regards to lung cancer, the odds ratio is only about 8. So it has a significant effect. Human papillomavirus is not only associated with cervical cancer, but other oral genital cancers. And you can see that for cervical cancer, the majority, 91%, is caused by the human papillomavirus. And this goes along with anal cancer, which about 91% is caused by the human papillomavirus. And unfortunately, cancers of the oropharynx and the anus are increasing in the United States, unfortunately, because of the virus. There are many types of high-risk human papillomavirus that have been linked to cancer. For cervical cancer, the main viruses associated with cervical cancer are HPV 16 and 18, and these make up about 70% of cervical cancer cases. The other 12% usually encompassing these other high-risk human papillomaviruses. The good thing about cervical cancer is there's an orderly progression from normal appearing cervix to mild to severe dysplasia to invasive cancer. And if we look as we get to a more severe lesion, the percentage of these lesions being made up and caused by human papillomavirus 16 and 18 increases from about 3% here in somebody who has normal to low-grade dysplasia, up to 50% in somebody who has carcinoma in situ, and then we come back to the 70% of invasive cancer lesions being caused by the human papillomavirus HPV 16 and HPV 18. Cervical cancer in general, for the past 40 or 50 years, we unfortunately haven't done a good job with regards to mortality for this disease. If we look here, although new cases are decreasing slightly, the mortality rate for cervical cancer hasn't decreased significantly as compared with other cancers if you look at SEER data. And in fact, the mortality rate for cervical cancer has actually been increasing in the past 5 to 10 years. We're not, as a community, we're not sure why that is that the incorporation of minimally invasive surgery into the paradigm, and we're still trying to sort that out. And so why does normal cytology fail us? About half of it is that women don't get screening if you look at women who develop cervical cancer. However, about a third of these patients are due to cytology not detecting the cancer when it's there. And so we need to try to come up with something better. If we look here at an Italian study of almost 100,000 patients, what we see is that when comparing human papillomavirus only as a screen versus cytology, human papillomavirus finds more cases of CIN3 earlier than a cytology arm. And then if you look on round 2, the 50 or so patients who cytology did not detect in round 1, unfortunately are picked up as cancer in round 2. And so human papillomavirus gives us a more accurate, earlier detection of CIN3. Additionally, adenocarcinomas are increasing in the United States. The incidence with regards to the general population of cervical cancer is increasing. And unfortunately, cytology just is not a good and accurate method for detecting adenocarcinoma precursor lesions. If you look here at a study we'll talk about more in future slides, the sensitivity of human papillomavirus testing was about 88% for picking up the adenocarcinoma histology as compared to 63% for cytology. So much better. Now, what happens when we add human papillomavirus to cytology with regards to picking up lesions of CIN2/3, severe dysplasia or greater? And you can see from a combination of almost 20,000 patients in a variety of studies that the sensitivity increases by about 35%. And the average sensitivity for cytology alone is anywhere from 55 to 60%. And that for human papillomavirus testing, again, much greater, around 90%. So which women, when we test them for the human papillomavirus, are likely to develop cancer at an increased rate and at a faster rate? And if you look at the study of almost 13,000 Italian women, very elegant, they took women and they screened all of the women initially for human papillomavirus, and then followed these women over a 10-year period. And what you can see here is that HPV 16 and HPV 18 cause severe dysplasia at a very increased rate and a quick rate. And so you can see here where the curves start to come up at 15 months is much greater than either patients who have a negative Pap smear or those, those patients who have a negative screen for human papillomavirus, or those patients who test positive for the other 12 high-risk human papillomavirus that we talked about. And if you can see here at the end of the study, HPV 16, about 20% of those patients develop CIN3 or greater, whereas a screen for the other high-risk human papillomavirus, although increased, is not necessarily as bad, quote unquote, as 16 and 18. About 1.5% of those patients will develop CIN3 at the end of the 10-year period. And those with a negative screen for the human papillomavirus, again, it can be seen that 0.5% of those patients will end up developing CIN3 or greater. So very informative for those tests. Now, the study that necessarily set the standard for primary HPV screening was the ATHENA trial. And what this trial did was screen over 50,000 women and divided them in a randomized fashion into 3 screening modalities. Patients were aged 21 to 65. Any abnormal Pap smear or positive HPV test went to colposcopy. Even if the colposcopy was normal, the patients were biopsied, and they enrolled about 1,000 women with a negative Pap smear and negative HPV test and also followed them. And so the patients were randomized into 3 groups. Women aged 25 kind of received the routine cytology that I grew up with. A Pap smear, if it's negative, you rescreen. ASCCS, you screen by HPV testing, and anything greater than ASCCS got colposcopy. Women who are greater than 30 received kind of the co-testing that you might be necessarily used to, in which we screen and triage patients with a Pap smear and HPV screening. If it's negative, you can rescreen in 5 years. HPV 16 or 18 positive get screened for colposcopy. And those who have ASCCS or greater go straight to colposcopy. And then finally, a group of women aged greater than 25, again, obviously, this would include women who are older than 30, were screened with primary HPV screening. And those women who had HPV 16 and 18 went straight to colposcopy. Those women who had the other high-risk subtypes had a Pap smear. If their Pap smear is normal, they're rescreened. And if they had ASCCS or greater, they went to colposcopy. And we see here a breakdown of those women who had a normal Pap smear. Approximately 1.2% of patients with a normal Pap smear had an incidence of CIN2 or greater. If we subdivide it by HPV type, those who had negative HPV testing, only 0.8% of the normal population had CIN2 or greater, versus 6% if those patients had high-risk type. And then again, when we subtype it back down to 16 and 18, about 1 in 10 patients were found to have CIN2 or greater. And so here we look kind of at the old strategy of Pap smear screening and HPV testing. If you had a normal Pap and they're HPV positive, the trend was then to repeat the Pap smear. However, if we look at the screening and subdividing patients by HPV 16, again, those subtypes which are high risk for developed cancer and at an increased rate, we get them in, we get them to colposcopy, and we find those lesions. And again, remember that in some studies, as high as 70% of patients are lost to follow-up. So if we can get these patients in, we can immediately test them for HPV 16 and 18, know what the high-risk population is, know what we're dealing with, and get them to colposcopy and treat them. If we look at the ASCCS population, again, if they screen positive for high-risk HPV, over 14% of those are going to be known to have CIN2 or greater, and 1 in 3 women who screen positive for HPV 16 are going to have CIN2 or greater. So again, all these patients are screened to colposcopy. The value of a negative HPV testing is also greater. If we look at the specificity of the test, those patients who have a negative Pap smear, their risk of developing CIN3 or greater is about 7–8%. However, if you look at a negative HPV test over 3 years, the risk of developing CIN3 or greater is almost half of that, or 0.34%. So the negative value of this screening test for screening for HPV is much greater. Now, when should we start screening patients? If you look at the ATHENA trial and look at a population-based distribution, the majority of abnormal CIN2 or 3 per 1,000 patients were seen in women who are younger, age 25 or 29. And so again, although there's been some discussion because of the increased rate of abnormal Pap smear or abnormal cytology in this group, that we should necessarily ignore it. But again, if you look at the percentage of CIN3s found in this group, as a population, it has more than any group here. And then when we look at the accuracy of Pap smear within this population, what we can see is that over half of this population, age 25 to 29, will have had a negative Pap smear and had underlying CIN2 or CIN3 disease. And so cytology, although in this age group, this young age group, just is not accurate enough in what we would want in this population. Finally, if we look at the percentage of both abnormal Pap smears and those patients screening for HPV 16 and 18, what you can see is the rate of abnormal Pap smears in this population, this young population, is still greater than the rate of HPV 16 and 18 positivity. And so again, the worry was, again, screening young patients, they have a fairly high rate of abnormal cytology, but the rate of positive HPV 16 and 18, which is what we're worried about, is lower than that. So it shouldn't necessarily add much additionally to our colposcopy workload. And here we can kind of see a breakdown of the three screening strategies and what was detected. And what you can basically see is that primary HPV screening detected more cases of CIN3 at baseline. It detected more at years 1 to 3, and there were only a need of 12.8 colposcopies to find one case of CIN3 in women aged 25 or greater. If we look at the women who are 30 or greater, again, primary HPV screening outperformed cytology in co-testing, detecting more patients at baseline, detecting slightly more at 3 years. Again, the reason the co-testing is picking up at 3 years because they're not getting them at baseline. And again, 13.1 colposcopies to detect one patient with CIN3. And so if we start screening women at age 25, we find 102 more cases at baseline, which required about 1,000 more colposcopies. However, if we look at the colposcopy rate, when we start at 25, the rate is 12.8, which is comparable to the 13.1 if we look at women who are greater than 30. And so it's more accurate. We pick up cases earlier. We prevent women from getting cancer, and the workload is pretty much the same with regards to 12.8 versus 13.1 colposcopies needed to detect the cancer. And so again, cytology-based screening is a modern success story in what we've done. It has limitations. Primary HPV screening is more sensitive, has a comparable positive predictive value and better negative predictive value than cytology screening alone. The great thing, again, kind of non-statistical term, is a positive HPV test, 16 and 18 particularly, identifies those patients at highest risk for dysplasia. And a negative HPV test is very successful at segregating those patients who are not at risk for developing cancer. Again, this just kind of reiterates some of those points. And so ideal case, we have a 26-year-old with HPV 16 positive, is referred to colposcopy. She was screened, she's young, she has HPV 16, she has CIN3, she gets a leap, and she's treated for her disease. Or you have a 26-year-old who has an ASCCP Pap smear, she gets a colpo, it's negative, you repeat her Pap smear, it's ASCCP again, she gets a colpo, it's negative, and this cycle goes over and over and over again until she's screened, and then we find out that she's high-risk HPV negative, or just as important, HPV 16 and 18 negative, which we could have found out earlier on and saved this patient unnecessary appointments and possibly a leap in other circumstances. I didn't talk much about follow-up, but it's rather easy. If you go on your phone and download the ASCCP app and become a member, which is fairly easy, it takes you through the algorithm. So it's nothing that you have to memorize. You can pull up, you can get your patient, put in their age, put in the screening values within the past 5 years. put what their test results were, click next, and anybody who has a greater than 4% risk goes to colposcopy. And so again, this app does all the work for you. You really don't need to memorize, and you can put in whatever special circumstances that you want. So again, that's just the ASCCP app, and it's very useful in clinical situations. I think that is all for me. Thank you.
Well, thanks for that summary. I'm trying to digest this as an old school primary care doc, and shift some of my thinking on all of this. And it's kind of hard to put your head around it a little bit. First of all, my big question is, can you take that app to your board exam and use it during the board exam for questions so that you can get the right answer? That would be nice. Yeah. All right. And so why don't I open it up for Gary or Anne-Marie, if you want to jump in and ask a question, and then I'll follow up with maybe a primary care type question. Anne-Marie, any thoughts or reflections on that? Or
well, I'm just curious in terms of I spoke with our pathologist at the hospital and asked her about the all these changes and the capability of the lab to even drill down and look for some of those other subtypes. Do you see any utility in checking for any of the other subtypes, or is it really only 16 and 18 that we need to focus on, which we do have the technology for?
Yes, because again, that would come into importance if you have an ASCCC or greater Pap smear. And so you screen initially for the 16 to 18, get them to colposcopy, but then otherwise you would get cytology on them. And then those patients who are of the other high risk types, you would direct them to colposcopy.
And then what would you do? I'm just curious, Dr. Farley, with a patient who's over the age of 65, who perhaps has HPV, has probably one of the low grade ones, not 16 or 18, but really never clears it. And you copal them multiple times, you don't ever find anything. They continue to be one of the lesser varieties of HPV positive. When do you stop screening that person?
Well, they would need a normal Pap smear, cytology, for 25 years after an abnormal one. And so unfortunately, once they've had an abnormal, you have to kind of keep them in the realm of screening. Yeah.
Interesting. So even if I have one gal who's 80 years old, and she said to me, how long am I going to have to keep doing this?
Yeah.
And which, yeah, I mean, and she's high risk HPV positive, or
not 16 or 18, but yeah, high risk HPV positive. One of the other
lesser ones. Yeah,
right.
As you can see, the lesser ones are although at increased risk, it's only slight above kind of negative HPV screening, but yeah, I would still watch her.
Gary, you want to read some of those questions in the chat there, or do you have a question? Sorry,
I have a question first, and that is, could you talk a little bit about Gardasil, and has that made a dent in this? Recommended? I mean, what would you say about kids and young adults getting vaccinated for HPV?
Yeah, I recommend vaccination for both men and women. As I kind of glossed over one of the slides initially, the HPV related cancers are increasing in incidence, particularly oral and anal cancers. And so obviously the disease spectrum is not limited to women. So I would recommend vaccination for, again, both men and women. And unfortunately, we're just not making a dent within the United States. Well, we're doing better with regards to vaccination. And I feel that kind of COVID is probably setting us back far with regards to trying to get our population vaccinated. If you look at countries like Australia, where over 90% of their eligible patients have received the vaccination, they've virtually eliminated cervical cancer as kind of a disease process within the country. And we vary anywhere between 40 to 60% vaccination rate in the country. So we definitely have to do better.
Okay, that's actually helpful. So there are a couple questions. Here's one. What efforts are there nationally in specialty societies to decrease the mental burden of positive HPV testing? It's so hard for young women exploring their nascent sexuality to find out something is broken, especially when an HPV infection is so prevalent. The repeated Pap smears, cytology, leap, et cetera, can produce harm in some of these patients. So it's that kind of mental burden.
Yeah, and a lot of it is having to do with education. I know if you go on our society, the SGO website or the Foundation for Women's Cancer, there's a lot of information and education and webinars there that talk about the human papillomavirus and can provide information to patients and education to help them with the diagnosis.
I would imagine that some women probably mistakenly consider it like an STD, and I think that's really what I've experienced in my, work, minimal work in the area as a primary care doc and screening and talking people through this, that this is not, chlamydia, it's got nothing to do with it. But
yeah, exactly.
It's difficult for people to process this. It's an infection, and there's an embarrassment factor to this.
Here's another one. Our current HPV testing tells us whether positive or negative for HPV, but does not specify types, 16 or 18. Are we ordering the wrong test?
You might be, and/or I'm not sure. What the institution necessarily says. Usually there are a variety of categories you can order with a Pap smear. You can order cytology, you can order ASCCP with reflex, you can order high-risk HPV testing, and it's just a matter of finding the right testing, communicating that to pathology and cytology so that it's ordered.
There's usually a reflex. I know for our lab, we use HereQuest. I can select if I want the HPV test to have a reflex to 16 and 18. So if HPV is positive, it'll reflex test them for 16 and 18, and I'll get a result that says HPV positive, but then below that 16 and 18 negative.
There's a question here about if someone was not sexually active, do you still recommend screening?
Usually if they're not sexually active,
or they have not, I guess the question is they've never been sexually active. So
if they've never been sexually active, then it's okay to wait till 30. But again, that's something obviously that you need to be, that needs to be you need to be sure about that. But yeah.
Mm-hmm.
There's a question: at what age do you stop screening patients for high-risk HPV?
65 or 25 years after any 25 straight years of normal screening.
And then one more. Unfortunately, we have issues with Medicare coverage of HPV testing. How do you handle that? I don't know if you...
And I will profess my ignorance. I just check the box.
Come on, Dr. Farley, could you please fix Medicare? We'd appreciate that.
Yeah, right.
We figured since you were kind of with the armed forces.
Yeah, that's right. Yes. Somehow you got away. Yeah. I plead my ignorance here. So is it, from the beginning of screening, are all patients getting Pap smears with HPV? Is that just naturally occurring now in all offices? And then if it's positive, there's a reflex to get either, to get the definitive, 16 or 18 high risk.
Yeah.
Is that standard across all practices now?
I would say probably not. I would say it's probably 50-50. I think the probably the most popular method, quote unquote, is co-testing. And so people will get the cytology and then reflex that for 16 or 18. But again, the societies, SGO and ASCCP are making the push towards primary HPV screening. And again, that insurance coverage is a great point. And as a society, we communicate with our representatives within Congress. So that's something that I can bring forward to that and to them.
I mean, I'd be shocked if Medicare does not pay for the screening, and particularly the further delineation of the genetic types.
Yeah, they'll approve. I've run into that. They'll pay for the Pap smear part, but they won't pay for the HPV testing.
Wow. Because, the example that I thought was, I always worry that some of these might lead to further unnecessary procedures. But in this case, if you have something like ASCCS, in the second case, that last case you presented with the woman that had recurrent ASCCS and was getting copos all the time. But if you have a negative HPV 16, 18, if I understood that correctly, you could have stopped the copo to begin with. Is that right? Did I understand that correctly?
Yes, if they had negative high-risk testing, yeah.
Right. So you would think if I'm Medicare, like, well, that's good for everybody. It's better for the patient. It's less costly.
Yeah. Less patients progress to cancer. You're finding it earlier.
Yeah.
And the cost to the system is much less.
There's one more comment. It says if positive, Medicare will pay for the aftermath, but not the primary test. There's another question from someone Dr. Andrew Rubenstein. What is your thoughts when Pap smears begin for a woman, and if she is not sexually active and completed her HPV series, does it need to start at age 21? So not sexually active, has had the HPV. I'm assuming that's Gardasil.
Yeah. No, I would begin them at 25. Yeah.
Yeah.
Well, Gary, maybe we should wrap up. I think this was just a great refresher. I think we need to distill it down to understand what do we want to do at CommonSpirit? Like, what is our standard here?
Yes.
And so, Dr. Farley, we may reach back out to you to kind of, one of the things we're trying to take these conversations and then think, do we really want to promulgate out a clinical standard that we all agree, at least we try, depending on insurance and things to that effect, but we're aspiring to all do that the highest evidence base that we can. So I think this is a good kickoff conversation. Yes. So we're going to continue to talk to you, Dr. Farley.
Absolutely, and any way we can help here in Phoenix, we'd be happy to.
Yes, I warned him, Tom. Before we'd be calling him up, but also, I think that I think we need to look at Gardasil also. I mean, and look at what our immunizations,
our rates look like, and how we're doing. Yeah, we should use that as a benchmark.
Yeah.
And I think your point, and I'm sure Dr. Jackson, Dr. Farley, you've seen a drop off in screening in general. I mean, whether it's getting the vaccine or Pap smear. I mean, it is. I think about the crisis we're about to hit in the next 5 to 10 years of all the missed screening, right? Because we're not going to see it in the next 6 months to a year. We're going to see this play itself out. And what are we responsible to do to try to help fix that problem? Maybe we think about really, just like we stood up these, big centers to do vaccines, maybe we need to do something like that to catch up on all the screening we didn't do over the last, 2 years of this pandemic.
Do you know, Dr. Farley, about home testing for HPV and any work in that direction? Because that's some of the stuff I've read. Yeah.
And there have been some studies that show that at least initially it looks like a viable alternative to in-office testing, and so that's definitely another direction that we can pursue in the future. Absolutely.
Then we have to tie in the follow-up. I think follow-up is the key, and I think in particularly underserved communities with on and off insurance, that's where it breaks my heart. We make some diagnoses, we get people at risk, and then suddenly we lose them and we don't see where they go.
Yeah,
And that's a challenge. So
yeah.
a lot in
And
front of
again,
us,
these-
good conversation. We look forward to continuing to work with you. Thank you, Dr.
Yeah.
Jackson.
You're very
Yes.
welcome.
Yep,
Thank
Dr.
you.
Farley, great. Thank you
Thank
so
you.
much.
Thank you.
More to come. Thanks, everybody. Have a great weekend. Be safe.